Hi friends and welcome back to Pulmonology. Today's clinical pulmonology part 2. After COPD, we are discussing today interstitial lung disease, a very important lung disorder. As you all know, ILD is a multi-system disorder, most of the time affecting the lung as an innocent bystander. So, what are the symptoms with which the patient presents? One is cough, which is mainly dry in nature, breathlessness, which worsens on exertion, wheeze. Okay, if the person with ILD has an wheeze, one of the following disorder has to be suspected. It is rheumatoid disease, hypersensitivity pneumonitis, sarcoidosis, and eosinophilic pneumonia. The other central airway diseases which also cause wheeze. Then if patient has substernal chest pain, we like suspect sarcoidosis. Then pleuritic chest pain, mainly in which like many diseases like CTD, rheumatoid arthritis and SLE, where they have pleuritis and then they lead to effusion. Okay, if the patient has pleuritic chest pain, we suspect those disorder. Okay, cough, bursitis worsening on exertion, wheeze, substernal chest pain, and pleuritic chest pain. And if the patient has hemoptysis, we suspect diffuse alveolar hemorrhage, mainly seen in SLE. So, coming to the system wise, we will divide the clinical manifestations based on the system. First is ophthalmological clinical features. The patient comes with dry eye. He says that repeatedly he has to put topical solutions. He has to repeatedly wash his eyes. Then it is a sign of dry eyes, commonly seen in Sjogren's syndrome. If the patient has uveitis, then mainly commonly seen in SLE and sarcoidosis. So after eye manifestations, we go for dermatological manifestations. And dermatological manifestation, diseases like dermatomyositis as heliotrope rash and Gordon's papules. Heliotrope rash is very specific for dermatomyositis. Here there is an reddish erythematous eruptions over the upper eyelid along with the edema. Okay, they can see that upper eyelid is swollen and it is reddish. Okay, those are for heliotrope rash. And when Gordon papules is on the distal end of your hand, will have reddish or violet type of papules. Okay, these are the Gordon's papules, seen mainly in dermatomyositis. And one more is SLE. SLE, as you all know, and they have mala type of butterfly type of rash on your cheeks, commonly seen in females. Okay? These are the dermatological manifestations. Coming to musculoskeletal system, most of the ILDs involving the musculoskeletal system have arthralgia, morning stiffness, and joint swellings, joint edema. And what are the diseases in which you see this? Rheumatoid arthritis, Sjogren's, and multiple connective tissue disorder syndrome. Okay, you see all these things. And one more thing, classical of scleroderma and SLE is Raynaud's phenomena, where there will be an alternate whitish and blanching of the skin, then followed by bluish and reddish skin changes. Seen mainly in Raynaud's phenomena. When you see all those things, like this, all this will just provide a clue so that you can investigate further based on this. Coming to the gastrointestinal system, esophageal dysmotility, the patient says that he can chew the food, but he has difficulty in passing it down through his throat. He has to repeatedly drink water, or he has to take a small amount of food so that it can enter. This is mainly seen in scleroderma and polymyositis because of the esophageal dysmotility. Then chronic aspiration, with the mainly seen in patient of ALS, amyotrophic lateral sclerosis or polymyositis, a neuromuscular type of disorder, where there will be repeated aspiration leading to lung inflammation and fibrosis. And one more thing is GRD. Well, in hiatus hernia patients, they'll be having GRD leading to ILD. GRD is one of the important treatable cause of ILD. So most of the patients which we treat on ILD, we put them on pantoprazole because there could be many times a silent ILD. Okay. Next, coming to respiratory system, uh, one of the most classical clinically how do you diagnose an ILD is one if the patient there is a more than 4% fall in saturation on exertion. But it is more or less the patient has an ILD. Like it's all the clinical symptoms are fitting. There are multiple diseases where there can be fall in saturation like COPD also, cystic fibrosis and diffuse involvement of lung by bronchiectasis. But if you are suspecting ILD on auscultation, one more important thing is Velcro creps, that the fine end inspiratory creps on auscultation if you find. And if you have more than 4% solid saturation, more or less yet your patient has an ILD. And use of accessory muscles, because most of the lung are fibrous, the patient will be using accessory muscles. So how these are all the clinical manifestations of an ILD. Clinically, how do you Just based on auscultation, how do you see that? How do you say that patient ILD is worsening? So what I do when a patient comes to my OPD, I auscultate him posteriorly from the basal or part of the lung. And if he has come to me today, I will write in my OPD sheet, like from the base, how much centimeter are the crepes. Like from the base, there are around 2 centimeter. Like I can hear the crepes for around 2 centimeter. I mark it there, 2 centimeter in my OPD card. And again, when he comes for follow up for after 2 months, 3 months, again when I auscultate, I see whether the length of the crepes on the base has increased. Like this time it is 4 centimeter, 5 centimeter. That means his ILD is worsening. Okay, this is how you clinically see the ILD is worsening. And if there's more, like for fall in saturation is like more compared to if he's walking the same distance, like last time I walked 250 meters and this time also I walked 250 meters, and this time fall in saturation is like or more than what it was there previously, then we say it is an like it is clinically worsening, and there is use of accessory muscles. Okay, and one more thing, one more point which I want to say is whenever the patient comes, remember C, D, E, and F. Okay, C to ask for history. History we need to ask in C, D, E, and F. Okay, C is to always rule out connective tissue disorder leading to ILD. D is for drugs. E is for environmental exposure. It could be smoking, biomass, or occupational lung disease, which where he work. And F is family history. Okay, all this C, D, E, and F. Okay, these 4 points should be ruled out before you arrive for a diagnosis of ILD. Okay, these are all the various manifestations: eye, skin, musculoskeletal, GIT, and respiratory system. Okay, thank you all for your patience listening. If you have any comment, please leave it in the comment box. Please share, like, and subscribe. Thank you all.